She will not show this time.
So the title of my talk is Imaging Prostate Cancer with Amino Acid PET, with an emphasis on Fluciclovine or FACBC. Yeah. There we go. Great. So these are my disclosures. I think the important one is that Emory University and Dr. Mark Goodman, who's our radiochemist, are eligible to receive royalties for this radiotracer. So let's start with a couple cases. This is a patient who's post-radical prostatectomy and lymphadenectomy and now has a rising PSA to 0.41. With fluciclovine imaging, or FACBC, we're able to detect activity in a sub-centimeter, probably about 5 millimeter, right obturator lymph node, which was biopsy positive for prostate cancer and changed the therapeutic approach to the patient. This is another case of a patient with a rising PSA post-local therapies, had a negative multiparametric MR and CT scan for extraprostatic disease, and in fact, they were noted to be unchanged from prior exams about a year earlier. On fluciclovine imaging, we saw uptake in about a 7 by 3 millimeter aortic cable lymph node, and I'm going to blow that up. It had a fatty hilum. This turned out to be malignant on laparoscopic biopsy and also changed the approach to the patient since it was extrapelvic. So these are examples of imaging with a PET radiotracer, FACBC, or the international nomenclature is fluciclovine. It is a non-natural allocyclic amino acid analog. But let's take a step back for a moment and kind of go back to basics in terms of the biology. So certainly advanced physiologic and molecular techniques have improved our ability to detect cancer and direct therapy. And these include a whole host of radiotracers from an actually repurposed older one, sodium fluoride PET, looking at bone turnover, to multiparametric MR, which also looks at various molecular characteristics, molecular probes used in PET imaging, targeted against various metabolomes or biologic aspects of tumors. And amino acids are one of those aspects, so we're going to concentrate on that part. Amino acids are utilized in protein synthesis. They're precursors of bioactive molecules and involved in energy metabolism. When I first started this work, I kind of had to go back to my medical school lectures because you kind of get distant from this when you're doing clinical work. So there's a real scientific basis for amino acid PET imaging. Amino acids are important nutrients for tumor growth. They're involved in cancer signaling via the mTOR pathway. And in fact, in many tumors, there's a metabolic shift in which glutamine is used as an alternative energy source to glucose. And in fact, there's been some work that targeting the transport of glutamine inhibits prostate cancer growth, in vitro at least, and in PC3 xenografts. Now, amino acid transport is upregulated in prostate cancer, and there are many transporters involved, and it's actually quite a complex system. The two major ones probably are ASCT2 and LAT1. Now, these are also known as the partners in crime, and they're associated with more aggressive behavior. Now, ASCT2 and another transporter, LAT3, happen to be stimulated by androgen signaling in androgen-dependent prostate cancer. So selected amino acid transporter systems have been targeted with radiolabeled amino acids. We're only going to be talking about the ones that have been specifically used for prostate cancer today. And this very nice slide is from a colleague, John McConaughey, who was at Washington University in St. Louis, now has moved to University of Alabama in Birmingham. So first naturally occurring amino acids have been labeled with carbon-11 and have been studied in prostate cancer. So methionine is kind of the prototypical naturally occurring amino acid, used mostly for brain imaging actually. But it also has been demonstrated to have a higher sensitivity for metastatic prostate cancer compared to FDG, which is our predominant PET radiotracer. And there has been some work showing the utility of methionine in retargeting cloning of initially negative prostate biopsies. Most of this work was done in the 1990s. Little work has been done since then on methionine. Now, another radiotracer, C11 hydroxytryptophan, is a neurotransmitter amine precursor. And we all know that there's neuroendocrine differentiation in prostate cancer. It's been linked to refractory disease, and also some early work was done with this radiotracer as well. Now, non-natural, non-metabolized amino acid radiotracers have some advantages over these naturally occurring ones, which are actually metabolized and go down a metabolic pathway in the body. So this is an example of where I would say the synthetic is better than the organic, though most of the time you want to try getting the organic when you go shopping. So first, the synthetic amino acid radiotracers can be labeled with fluorine-18. Now, fluorine-18 is a longer-lived radionuclide with a 110-minute half-life versus the 20 minutes of carbon-11. So it makes it much more practical to produce and distribute over a wider area. Effectively, you'd have to have a cyclotron in your facility or maybe right next door to do much carbon-11 work. There's a simplified radiosynthesis. It's non-metabolized, as I mentioned, so there's more straightforward kinetics, and this lack of accumulation of metabolites in non-target tissue is actually considered an advantage for imaging. So this is a picture of the molecule of FACBC or fluciclovine. So a little about the history. This radiotracer is based on a synthetic amino acid which was developed in the 1960s called ACPC. And this was developed in the hopes it could be a therapeutic agent for malignant tumors. And the mechanism of action was thought to be competitive inhibition of valine synthesis by tumor cells. It turns out that to have any effect, you had to use so much of it that it actually caused toxicity. But with diagnostic procedures, we use trace amounts, and that's a totally different ballgame. So a radiotracer based on this parent molecule, ACBC, labeled with carbon-11, was developed at the Oak Ridge National Laboratory in Tennessee in the US, and they also do some medical work there. So intense ACBC uptake was noted both in animal models and humans in a wide variety of tumors. They hadn't done any work with prostate cancer, though. There was relatively little renal excretion and minimal normal brain uptake. So we'll discuss that in a second. So when Dr. Goodman, who's our radiochemist, came to Emory, and he actually had done some work at Oak Ridge, he synthesized a fluorinated variety of this called FACBC, and it was investigated in vitro in small animal models. Now, the advantage here, this doesn't always work out this way, but it had similar imaging characteristics to the carbon-11 variety, including low normal brain uptake and little renal excretion. So the initial focus was on the brain, and that work continues, and there's actually some promising data coming out of Japan, as well as hopefully our institution from some trials that are ongoing. But as far as the little urinary excretion, we thought that it could possibly be an advantage in looking somewhere along the GU tract for tumors. So when I came to Emory, I was looking for a project. This was suggested to me. You know, we haven't really looked at this on a whole body basis, and you might kind of want to look at it. I got a small grant, and actually we started with renal cell carcinoma. So in a small group of patients, didn't turn out to be much of an advantage for renal cell carcinoma, but in one of our patients who was known to have prostate cancer, and it was discovered that it had retroperitoneal lymph nodes. We thought that this was going to be renal cell cancer with retroperitoneal metastasis. But it turns out that this mass was a Rose-Dorfman lesion. That was good for the patient. But unfortunately, these nodes that lit up in the retroperitoneum were biopsied, and this was unexpected metastatic prostate cancer. Actually, PSA was not quite that high. So this led us to do a pilot study at first in a small group of patients with some promising results looking at FACBC or fluciclovine with prostate cancer. So this is an example just from some of that work. Admittedly, this is a pretty enlarged node. You would call this even on a non-contrast CT, but it really lit up with the fluciclovine. And our comparator at the time was Prostate. Really, there was no significant activity there. So work also continued on kind of the basic science part of this, mostly from our colleagues in Japan. And it was at first thought that fluciclovine was mostly transported like leucine. But it turns out that it's probably transported more like glutamine. And why is that important? Well, glutamine is actually an important substrate for tumor metabolism, with predominantly probable system ASCT2 transport and a lesser contribution by LAT1. Those are the two partners in crime. It's possible that LAT1, though, may predominate in acidic tumor conditions and maybe also as the disease transforms to castration resistance. Some more in vitro work showed us that fluciclovine had greater uptake than glutamine, methionine, choline, and acetate, at least in these cell lines in vitro, and that dihydrotestosterone increased fluciclovine uptake in AR-positive LNCAP cells. Now, these systems mediate both influx and efflux. That is, that this LAT1 and 2 and ASC are one-to-one exchangers. So an amino acid must go out for one to come in. And that's probably the reason for actually what I call the unkind time activity curve. So there's a washout of fluciclovine in most lesions. And in many patients, a downsloping time activity curve. Some have more of a plateau. But that's why we image in this first 30-minute time period. And early imaging, therefore, is recommended. Now, as far as whole body biodistribution, for those of you who are used to FDG images, these images look very different, probably a little more like choline, but with some important differences. So most intense physiologic uptake is in the liver and pancreas. That's pretty common for amino acid radiotracers, with more moderate activity in salivary glands, pituitary. Muscle increases with time. Marrow is a little more heterogeneous than FDG, and it decreases with time. Mild to no brain activity and variable bowel activity. But unlike choline, bladder activity is mostly absent or mild on early imaging, but it does increase moderately with time, though nothing like FDG. And there's a minority of patients who we see some more activity from an early time point, still trying to get a real handle on that. Again, not nearly as much as FDG. So this is a positive node for prostate cancer in the pelvis on this projected image. And we could see over time there's some fading of that node, and we could see just our biodistribution pattern. The bladder does start showing up a little later on, but again, the activity is mild to at most moderate. As far as dosimetry, it's been studied at 3 different facilities now. Bottom line is differing methodologies, but the total dosimetry is typical for common PET radiotracers like FDG. So that's a take-home message from that slide. We recently completed a 115-patient National Institute of Health sponsored trial of suspected recurrent prostate cancer, and we were using multi-time point fluciclovine. So these are just some results from that trial. Overall, there was an 82% positivity at all PSA levels, and like with many imaging, as our PSA drops below 1, our detection rate does decrease. Though even at 39% at that low PSA level, it's not bad. And a lot of this also depends on PSA kinetics. So you can have a lower PSA, but if you have a higher velocity or faster doubling time, there's more of a chance that an image will detect a tumor. So we published a sub-analysis of this study in 93 patients who we had patients who had Prostate, and that's actually what the NIH was paying us to do at the time, to compare it to Prostate within 90 days of each other. A strength of this study was, first of all, we separately powered and calculated diagnostic performance in the bed and in extraprostatic locations, because we believe that's the most clinically relevant way to look at things. And another strength is that In 100% of the patients we called true positive in the prostate bed, we had biopsy proof. And in nearly 90% of the patients we called true positive for extraprostatic disease on a per patient basis, because we can't biopsy every lesion, obviously, we had biopsy proof. Our negative standard of truth was essentially biochemical control, which is a pretty high bar. So see, these are some of the results from that study published in Journal of Urology. As far as the prostate bed, higher sensitivity than Prostate. There is a suboptimal specificity. I think there's some confounders there that I'll be discussing, but a decent positive predictive value. As far as extraprostatic disease, looking at all comers at all PSA levels, sensitivity was significantly higher than Prostate. And importantly, we had high specificity and high positive predictive value throughout all patients. Bottom line is that Fluciclovine PET correctly upstaged about 26% of patients. Not surprisingly, it outperformed Prostate. These are some images. There's a patient with a PSA of 0.9 post-prostatectomy. FACBC was positive at the anastomotic area. This was biopsied positive. The patient underwent salvage radiotherapy of the prostate bed, and then we had a persistent PSA nadir, which proved the negativity of the remainder of the exam. And that's kind of an example of how we prove the negatives, which are difficult. This is a patient who's PSA 1.1 post-prostatectomy, CT, bone scan, Prostate were negative, negative transrectal ultrasound and biopsy. The standard of care at that point is to irradiate the prostate bed in a post-prostatectomy patient. I remember this patient well as a pilot. It was one of our first studies, actually, and we detected activity in a 5 millimeter left obturator node. And I have fantastic interventional radiology colleagues who were able to biopsy many different lesions, including this one, and this was recurrent prostate cancer. It obviously changed the therapeutic approach to the patient. Now, we also looked at a comparison, and this is being prepared now for publication, with a CT scan and a subset analysis. The primary aim was Prostate, but many patients also had CT scans as well. The denominator here is going to be smaller because they were done over a longer period of time. So when we take the ones that are also done within 3 months, we see sort of a similar trend. That Prostate, outperforms CT at every PSA level and overall. Now, also looking at sub-analyses, when we look at doubling time, as with other radiotracers, the shorter the doubling time, the higher the detection rate with FACBC. We kind of had the opposite with CT, and I think this is just kind of a statistical variant because there were so few detected with CT, because it should be the same kind of trend if you think about it. And as far as looking at original Gleason score, patients with a higher original Gleason, when they recur, have a higher detection rate with Fluciclovine, so when they have biochemical failure. Some interesting work has been also completed at University of Bologna, in which they've done an intra-patient comparison to C11 choline. So these are patients with radically treated prostate cancer and biochemical relapse. So the PSA levels tend to be a little lower kind of in that group of patients. Both studies are done within 1 week of each other. They're doing single time point Fluciclovine, which is going to become, I think, the practical standard of performance. 89 patients were included in their final analysis. All in all, Fluciclovine outperformed choline, both on a per patient and per region basis. A little better sensitivity, but significantly better specificity. And what they also considered a better interpretive ease. Bologna does a lot of choline patients as well, so they thought the Fluciclovine was a little easier to interpret with fewer pitfalls. Production may also be an advantage, and of course there's the advantage of the fluorine, though of course fluorocholine has a longer half-life as well. There also may be some advantage at lower PSA and smaller nodes. in some of the data, but I think that needs a little more study and analysis. So I'm going to show you some examples, and this is courtesy of Cristina Nani and Stefano Fanti at University of Bologna. Here we have a nice case of recurrence in the bed, seen with fluciclovine, but really negative on choline. A nice concordant case of positive choline and fluciclovine. For extraprostatic disease, this is a case of lymph node lighting up with fluciclovine, but really not with choline. There was surgical proof here. And to be fair, there were some instances of the other way around. This is a case in a small aortic cable node where choline visualized better than fluciclovine. Interesting case of a bone island. This was proven to be a bone island on follow-up, but this actually had choline activity, while the fluciclovine was true negative in that area. This is also kind of a fascinating area, I think, for future research, really using these radiotracers to help tease out tumor biology. So this is a case of a patient with a PSA of 4.6, a fairly short doubling time, and there was definitive focal activity with fluciclovine, little asymmetry with choline, not enough really to call. About a year later, the choline became much more positive. And there were some cases of the other way around where, now here on CT, this would be like slam dunk call, prostate metastasis on the CT scan itself. Choline here was more intense than fluciclovine. Now, we think that, I think fluciclovine will have its greatest utility with recurrent prostate cancer in terms of prostate cancer. As far as detecting disease in the primary gland, work that we've performed showed decent sextant level sensitivity, but really suboptimal specificity in the untreated prostate itself. And while SUV max significantly correlated with Gleason score, that's intensity of uptake, there was overlap. So we concluded that fluciclovine PET should not be used alone for radiation therapy planning, but could be useful to guide biopsy to the most aggressive lesion. Another study done actually much more elegantly than we did ours by Baris Turkbey at the National Cancer Institute, and he was comparing to multiparametric MR. Multiparametric MR did significantly better overall on a per lesion basis than fluciclovine. And while there was higher uptake in cancer versus normal prostate with fluciclovine, the confounder here is benign prostatic hypertrophy, which actually had a similar uptake. Interestingly, though, if MR data is used in combination with PET, the positive predictive value is higher than either modality alone. So there is ongoing research using multiparametric MR and fluciclovine PET to help better direct biopsy and stage the patient, possibly maybe in high-risk primary disease. One of my colleagues, Bowie Fay, in my department is an engineer by training. And he is working on a system where we co-register molecular imaging information, or we could also do it with MR, into an ultrasound biopsy plan. And this directs our urologists to biopsy certain areas and kind of know where we're going. So this is an example of that. This is a patient who had multiparametric MR. I'm not showing you all the sequences here, and fluciclovine. And they were concordantly considered positive in the base. We could see her brachytherapy seeds here. And in the apex, fluciclovine, we considered it positive, while actually multiparametric MR and the other parameters was read out as nonspecific activity. When we directed biopsies to both those areas, tumor was present in the base and the apex. Now, there's also been some case reports on radiotherapy planning, both from our group as well as the Bologna group, where fluciclovine was used to guide salvage radiotherapy. And in a more formal way, we're studying this at Emory. One of my colleagues, Ashish Jani in radiation oncology, is a co-PI on this with me, where we take patients who are post-prostatectomy with any detectable PSA, actually, and biochemical failure. And they get planned or simulated first based on conventional imaging alone, which today involves mostly MR. And one arm of the study, this is randomized prospective trial, the patients also get fluciclovine. And we see how it changes management and the radiation therapy plan and approach to the patient. Ultimately, we'll be looking at PSA-free survival as well. Preliminarily, the use of fluciclovine when we do this has resulted in a nearly 30% change in radiotherapy management decisions. Most of this is involving the radiotherapy field, but also with the decision to give therapy in a minority of patients. I've also completed a 25-patient trial with patients who are non-prostatectomy with biochemical failure. They have multiparametric MR and fluciclovine PET-CT. We actually also have fused it afterwards and kind of co-read them. There's a genomic tissue analysis of this as well, and we're really starting to sift through the data now. But anecdotally, first of all, certainly MR adds anatomic definition to the fluciclovine PET-CT. And there is more confidence in some cases on both sides, especially in borderline bones or nodes. But I could tell you, and I think this will affect as the PET-MR devices are coming out now, very expensive, more data may not necessarily be better, and sometimes it actually leads to confusion. So I think it's been a real challenge on how best to combine this information from fluciclovine and MR parameters, especially in the post-therapy bed and the post-therapy situation. But work is ongoing. So this is one illustrative example. Patient is post-EBRT, had short course androgen deprivation therapy at one point, and brachytherapy, a rising PSA. Now there was concordant uptake in the prostate bed on both multiparametric MR and fluciclovine, as well as within about a 1.5 centimeter right pelvic lymph node, which we see here on the MR, and with fluciclovine. But MR also predicted positive nodes bilaterally in the pelvis, while fluciclovine was negative in those smaller nodes. In addition, the MR predicted that a left sacral lesion was going to be metastatic disease. So this obviously is a very different interpretation affecting the patient. One is going to be local regional, one is going to be systemic if you believe one or the other. So the and fluciclovine, by the way, was negative in this, essentially negative, in that sacral lesion. So we performed an MR-guided biopsy of the sacral lesion. It was not malignant. And a salvage nodal dissection was performed and revealed malignant nodes only where there was fluciclovine positivity. So there were no malignant nodes on the contralateral side. So only where there was concordant activity in the studies where the patient had evidence of disease. Now, I'm also going to talk a little here about interpretation of the studies. Just by show of hands, urology, okay, and rest is radiology, nuclear medicine, and okay. And some others from students, general students, okay. So I think it's kind of interesting just to go over how we would interpret these studies. This is not meant to be official reader training, but, and also we have kind of a mixed audience here, but I suspect that the surgeons, urologists at Oxford, just as the surgeons at Emory, look over all their images and on all the patients and get pretty darn good at interpreting studies. So,
not sure about the last bit.
Okay. I know ours are kind of challenging, even at tumor board. So, first, as with any other imaging modality and other radio tracers, there is incidental uptake patterns that one has to be aware of. and normal variants. So for example, other facilities who've been using it have demonstrated, for example, fluciclovine uptake in this osteoid osteoma, meningioma. There can be mild symmetric inguinal nodal uptake. It usually fades on delayed imaging if you do that. If you're doing single time point imaging, I think you just have to read around it. This particular patient had more enlarged nodes, a little more intense activity, turned out to have a ringworm infestation. Now, as far as inflammation, amino acid imaging is believed to be less prone to false positive inflammatory uptake. But we know that amino acid transporters are actually overexpressed in benign inflammation as well. So there's probably some advantage compared to FDG, especially in acute inflammation, but it's not, there's no immunity to inflammatory activity. We see that with other imaging as well, including, for example, multiparametric MR. So if you're interested in reading more, we published kind of a normal variance paper in Journal of Nuclear Medicine in 2014. So let's go to some cases. First, in terms of post-prostatectomy, okay, I think that the sagittal images are really useful here. There is a normal physiologic periurethral activity. And what we're looking for is focal non-physiologic activity with intention to the anastomotic area of the bladder and the urethra, especially if it's at least equal to or greater than lumbar marrow. So this is kind of an easy case. There was obviously intense activity where we'd expect a recurrence, and this was biopsy proven. This patient, though, here we see our urethral activity, and there is really no, it's really periurethral activity, no activity in the anastomotic area, therefore we would call this negative. But in this a little more subtle case, we kind of see this bump with focal activity in the anastomotic region, and this we would call positive, and this was a biopsy-proven case. Now, as far as non-prostatectomy, typically we want to look for focal asymmetric activity, maybe a little higher bar, visually greater than marrow. Would be suspicious, but one wouldn't call mild diffuse activity. So this patient had focal activity in the prostate. Actually, these are fiduciary markers from radiotherapy. This was biopsy proven. Patient underwent cryotherapy. We actually ended up doing a follow-up fluciclovine scan. That activity disappeared on this patient. This is the kind of activity I would call in the prostate, this focal, fairly intense activity, but this mild diffuse activity would not call positive. This patient had extensive retroperitoneal malignant nodes, we could see here, extending up into the thorax. They're in typical locations for prostate cancer spread, but this mild diffuse midline activity in this treated prostate, again, would not call that positive. Now, as far as nodes, it's been shown that nodes can sometimes skip around a bit in recurrent prostate cancer. They don't always have that logical progression. So in this patient done at a different hospital, there was activity in precoronal and right paratracheal nodes. We could see that here. There was no biopsy proof here, but they did enlarge on subsequent imaging as PSA got elevated. This patient is a rising PSA post-EBRT and brachytherapy. MR was also negative for extraprostatic disease. We saw fluciclovine avid subcentimeter right cum and iliac and obturator nodes, and these were malignant on laparoscopic dissection. Unlike FDG, where one sees activity in that area and you immediately think about ureteral activity and you kind of use the coronals, go up and down. That doesn't happen as much with fluciclovine, and those turn out to be nodes. You just have to kind of look carefully for them, especially if they're sub-centimeter. So with experience, though, you can even allow for partial volume effect with PET, where small lesions get underestimated in terms of activity because of the physics of the scanning systems. So, for example, these tiny nodes, they're in suspicious groupings. These are sub 5 millimeter. And these are equivalent to marrow, but these are the kind of things with experience that I would still call positive, and these invariably do turn out to be true positive when we go after them. So understanding the patterns of spread is important. That is a general, I think, imaging philosophy or principle. And you really do want to have a higher sensitivity in areas where you know whether it's prostate cancer, rectal cancer, lung cancer, where tumor normally spreads to. So I wouldn't, for example, call inguinal and distal external iliac nodes positive in isolation, only if they're marching out maybe asymmetric and hot from clear disease in the deep pelvis and there's no maybe nearby causes of potential inflammation. So this kind of idea of reading from the inside out with prostate cancer, I think, is a good approach. So here we have a patient with intense activity in an iliac bifurcation node that was malignant, but would not call this mild symmetric inguinal and distal external iliac nodes positive on our early time point imaging. Similarly, this patient is 5 months post-radical prostatectomy and pelvic dissection with a rise in PSA. Who have a positive sub-centimeter retroperitoneal and deep iliac lymph nodes here. Now, these are hot for their size. They're small, so they're being underestimated, and they're typical locations for spread, but would not call the mild inguinal activity here positive. Now, this is the flip side. This patient has a rising PSA post-therapy, positive multiparametric MR in this 1 centimeter retroperitoneal lymph node, and there was actually an adjacent lymph node as well. But on fluciclovine, really, there was no significant activity there, just maybe very mild. We expected, by this time in our experience, that size node to be hotter, much hotter than it actually was. So we questioned if that node was truly malignant. Did a biopsy of that node, and it was benign. So that's kind of the opposite way where you can also help it with negativity. Now, as far as bone lesions, our overall experience is that fluciclovine has intense activity in lytic lesions, less common in prostate cancer, moderate and mixed lesions, and there actually may be absent activity in indolent sclerotic lesions. So skeletal specific imaging is recommended. And there seem to be instances in some recent series at other hospitals in which there's fluciclovine uptake in bone when conventional imaging and choline are negative, and some vice versa as well. Here we have a patient, PSA 2.97, post-prostatectomy. Bone scan was negative. And we had intense fluciclovine activity in the pubic ramus here, very subtle kind of erosion. And honestly, this is one of our early cases as well. I thought this was going to be false positive. This directed a biopsy to that site, and indeed, it was a metastasis. Now, when we see activity with FDG around the end plates or in Schmorl's nodes, we just say, yeah, degenerative activity, no problem. But with fluciclovine, we really don't see that normally. So if we see activity in something that looks like a Schmorl's node, as here, I would call that positive. And this actually turned into a much uglier lesion later on. But in this dense sclerotic lesion, there was no fluciclovine uptake. And this actually also definitely turned out to be a bone metastasis. Here we have a patient post-radical prostatectomy. PSA is 1.1 post-op. There's a tiny little sclerosis, kind of subtle here. It's at the end plate. With FDG, degenerative. But with fluciclovine, this is the kind of thing I would call positive. And this, the MR was actually initially negative. It subsequently became positive in that area. Another patient, radical prostatectomy, salvage radiotherapy, now rising PSA, slam dunk positive left sacroiliac bone metastasis, and a 5 millimeter left deep iliac node, kind of tucked behind there. You start getting used to seeing these when you're doing this kind of imaging. And this activity was similar to marrow, but hot for size because it's being underestimated. And this indeed was a positive case. Now, as far as the current status of fluciclovine, a NDA or new drug application has been filed with the U.S. Food and Drug Administration for priority review based on data from over 700 cases now from the U.S., Norway, and Italy. There's also an orphan drug indication for glioma. The Falcon trial is up and running in UK, and I know at your facility, and some patients have already been recruited and scanned. And there is a phase 3 Locate trial for also management change with biochemically recurrent prostate cancer in the US, which is imminently about to open. I will discuss a little about emerging amino acid tracers besides fluciclovine. Fluciclovine's not the only game here. This is an interesting kind of history here. So remember we talked about the parent molecule ACPC. Well, Dr. Goodman developed a homologue of fluciclovine called FACPC, which demonstrated high uptake in the DU145 cancer cell line. So it looked great on paper. But when we got it in a human, and we actually did FACPC and FACBC in 5 patients, and we did both scans. It's kind of hard to get patients to volunteer for 1 research scan, let alone 2. Very aggressive research associate at the time, who's now actually an attending at Loyola in Chicago. And what we found with FACPC, though it looked good on paper, the imaging characteristics for prostate cancer were not as good compared to fluciclovine due to early high blood pool activity and delayed much greater bladder activity. So this is a nice example of the gap or sometimes chasm between a bench to bedside when we develop things. Other amino acid systems of transport, system A may actually have some advantages because it's actually concentrative rather than an exchange mechanism. This is some work from Japan with a carbon-11 radiolabeled system A tracer with prostate cancer. And we've developed a fluorinated system A PET tracer, but it's at the preclinical stage right now. Interesting work done at Stanford. In California, a glutamate derivative, fluorine 18 labeled, showing some nice results with prostate cancer as well. And this particular radiotracer has not been yet tested with prostate, but I think it has some interesting possibilities. Susie Lappy at WashU at the time developed a zirconium-labeled antibody tracer for the LAT1 transmitter itself, transporter itself. And this could have applicability to a wide range of cancers and may actually provide superior tumor visualization, though I think there'd probably be a much higher radiation dose. But there may be some possibilities here for therapy, but we'll see. More on that in the future, hopefully. So in conclusion, imaging with amino acid-based radiotracers is promising for prostate cancer, not only as a tool for experimental science, but to help us diagnose and stage patients and potentially better understand tumor biology. Thank you very much for having me. I'd also like to acknowledge our entire collaborative team. So you've heard kind of it takes a village. I think it takes a world to do this kind of work, and a lot of people, a lot of institutions really were involved. So